Hello, everyone. We will take a few minutes to let people join the webinar, and then we will get started. Hello and welcome to TMA's Empowerment Clinic on getting a good night's sleep. My name is Rachel Bromley and I will be your host this evening. I am TMA's Senior Manager of Patient Education, Support, and Advocacy. And today we have the honor of speaking with Dr. Sushila Hadigal. And Dr. Hadigal is a board-certified pulmonary critical care and sleep medicine physician based in Florida. With over 14 years of experience, she has established herself in sleep medicine. She is known for her expertise in diagnosing and treating sleep disorders such as sleep apnea, insomnia, and narcolepsy, as well as pulmonary conditions such as asthma, COPD, and interstitial lung disease. After graduating from medical college in India, Dr. Hadigal moved to the United States to pursue a residency in internal medicine, followed by a fellowship in pulmonary and critical care medicine. She then pursued further training in sleep medicine, earning her last certification from the American Board of Sleep Medicine. Throughout her career, Dr. Hadigal has demonstrated a commitment to providing her patients with the highest quality of care. In addition to her clinical work, she is actively involved in research and teaching. She has authored peer-reviewed respiratory and sleep medicine articles and frequently presents at national and international conferences. She is a faculty member at the University of Florida and a staff physician at Malcolm Randall Medical Center. She is the Associate Program Director for the Sleep Medicine Fellowship. She also mentors nurse practitioners, physician assistants, medical students, residents, and pulmonary medicine fellows. Dr. Hadigal, it sounds like your circle of influence is huge.
Yes. Thank you so much for having me talk today. Good evening, everyone. It is my pleasure to be associated with the Myositis group and give this talk about sleep. I also wanted to say we have recently started a Myositis Center here in Gainesville, and we are seeing civilian patients at the University of Florida and veterans in the VA Malcolm Randall Center. And it is a multidisciplinary clinic that we run with multiple specialties. And if anyone is around the area and needs any help, please let us know or reach out to us.
Thank you so much. That is an amazing staff you have there. I went to their first support group meeting last week, and I was so impressed with the passion and commitment of everybody at the University of Florida Myositis Center. And thank you for your help, because I understand you sometimes see myositis patients as well, correct?
Yes, sometimes when they need any help with like CPAPs and BiPAPs, I'm definitely ask questions, and we just have like rooms adjacent to each other. So that's what works out best in our setting, I think.
That's good. Well, go ahead and share your slides and we'll do your presentation. And then we will have another guest, a patient with myositis who has overcome sleep difficulties. And we will talk with her after Dr. Hadigal's presentation. So go ahead.
Okay, so getting a good night's sleep, and I'm gonna just talk about a couple of things regarding normal sleep pattern and the stages of sleep, a few other sleep disorders, and what we must focus on if we have trouble falling asleep or staying asleep. So why sleep? Why are we talking about sleep? What is so important about sleep? A lot of people ask me this question when they're referred to my clinic by other physicians, and they're like, it doesn't bother me, is what everyone thinks. But what we have to remember is sleep is an integral part of our daily routine. We spend about 1/3 of our time sleeping. It affects almost every tissue and system in the body, from the brain, heart, lungs to metabolism, immune function, and mood disorders. Without sleep, we cannot form or maintain the pathways in our brain that let us create and learn new memories, and it's harder for us to concentrate and respond quickly if we do not have adequate sleep. So how do we regulate sleep? There are two key drivers that we have to remember. One is the sleep-wake drive, and the other is the circadian system. So the sleep-wake drive, simply put, it is the longer we are awake, the more we feel the need to sleep. This is because of the sleep drive, the body's self-regulating system in which the pressure to sleep builds up based on how long you've been awake. And this same drive causes us to sleep longer or more deeply after insufficient sleep. And the circadian system is our biological clock. Circadian rhythms last roughly 24 hours and play a central role in numerous biological processes, including sleep. And light is light exposure influences our circadian rhythms and encourages wakefulness during the day and sleepiness at night. So I wanted to talk about normal stages of sleep, and I'm going to get my pointer here. Okay, so during the night, our body goes through different stages of sleep every 90 minutes. We go through non-REM sleep, that is stages N1 to N3, and REM sleep, that is stage R. There's like four cycles or 5 cycles of sleep that we go through. And depending on the age of the sleeper, sleep stages change. And usually N3 and REM sleep are known to have like significant unique benefits. And as you can see in this, what we call a hypnogram, they were awake, fell asleep, you go to N1, N2, N3, and then you go into REM sleep, and then you kind of cycle around. And to the end of the night, your REM sleep is more compared to during the first third of the night. So the sleep architecture is something we talk about, the same thing in terms of like sleep stages. So N3 is the most important restorative sleep stage from which it's difficult to be awakened. This phase of deep sleep is what helps us feel refreshed in the morning. It's also the phase in which our body repairs muscle and tissue, encourages growth and development, and improves immune function. REM sleep stage is critical for learning, memory, daytime concentration, and mood. So during REM stage, our body experiences faster and irregular breathing, increased heart rate, and increased blood pressure, but we are paralyzed in terms of not being able to move our arm and leg muscles. And this way, the body has this mechanism set in so you do not act out your dreams. And as I said, REM sleep increases with each new sleep cycle, starting at about 10 minutes during the first cycle and lasting for up to 1 hour in the final cycle. And that's important to know because some people just tend to sleep like 4 hours or so, but sleeping through the night, the entire 7 hours is definitely beneficial in these terms. So then the other question that we always have is, what is good sleep quality? The way we estimate it when we as physicians talk to you to understand how your sleep is 4 things that we try to kind of figure out, and that is sleep latency. Latency is like how quickly are we able to fall asleep. Falling asleep within 30 minutes or less after the time you go to bed is good. It's good quality sleep. And then the number of times we wake up for more than 5 minutes, waking up once or not at all, wake after sleep onset. Like if you fall asleep and if you're awake for 20 minutes during the night, that's good. Anything more than that is again considered like poor sleep quality. And sleep efficiency, the amount of time you spend sleeping while in bed, it should be around like 85% of the time. So these 4 things is what we take into consideration in terms of sleep quality. And healthy sleep duration. So on this chart, you can see that like a 4 to 12-month-old needs a lot more sleep, half a day, 12 to 16 hours. This is including nap time. And as we get older, we need lesser sleep. So 18 plus years of age, we recommend 7+ hours of sleep. A minimum of 7 hours is what is usually recommended by the American Academy of Sleep Medicine. And then I'm going to talk about sleep and other medical disorders. So sleep and depression, in a recently published poll result by the National Sleep Foundation, strong associations between sleep health characteristics and depressive symptoms were observed. So, half of all individuals who reported less than 7 hours of sleep per night also reported mild or greater levels of depressive symptoms. And nearly 65% who were dissatisfied with their sleep reported again mild or more levels of depressive symptoms, with 31% reporting moderate to severe symptoms of depression. And nearly 2 in 5 people who have difficulty falling asleep or staying asleep just 2 days a week also reported mild or greater levels of depression symptoms. So sleep and depression or any mood disorders are very well interconnected, and we have to pay attention to how much we sleep if you want to overall feel better. And now getting into sleep disorders and myositis. So many medical conditions have ongoing insomnia complaints associated with them, especially those that cause some form of ongoing pain or discomfort, mobility limitation. For patients who have myositis, lack of sleep can cause flares in muscle weakness, pain, and skin symptoms, as sleep deprivation is associated with markers of inflammation. Also, what is extremely challenging, I think, for myositis patients is that being on prednisone, and especially chronic prednisone, which can cause insomnia and have effects on your mood and how you feel the next day also. So coming into the pulmonary complications of what we see in myositis, aspiration, pneumonia, hypoventilation, and interstitial lung disease. Respiratory complications are common, but ventilatory insufficiency is not always seen in patients, but something to keep in mind. Um, if you have like fatigue or so, this is something I would be thinking about in our patients. And positive pressure ventilation, what we call CPAP at home, can result in improved chronic hypoventilation symptoms. I also wanted to talk a little bit about like the common disorders of sleep. I picked the three common sleep disorders, I should say: insomnia, sleep apnea, and restless legs. So getting into insomnia. The way we define insomnia is unable to fall asleep, stay asleep, and waking up feeling unrefreshed. And this occurs despite an appropriate environment for you to sleep, and can result in daytime sleepiness, being tired, and reduced productivity. And the treatment for this, what is gold standard of treatment is what we call CBTI, so cognitive behavioral therapy for insomnia. It is the first line of treatment. It has long-term effects and does not carry any risks. It is provided by a licensed psychologist trained in this type of treatment, and they help identify, pinpoint the problem and replace it with like healthier beliefs and attitudes. I'm not going to talk about medications today because medications can be used in conjunction with CBTI, but we believe this is the first step where we have to make sure all the basics for adequate sleep, sleep hygiene are set. And as I said, medications can be used in conjunction either for short term or for a limited period of time, but long term use of medications has its own side effects. So getting into what they do in CBTI. So sleep education and hygiene is what we're going to talk about. So initially I spoke about like light, how it can affect our circadian cycle. So light can influence one of our sleep regulators, the circadian system. It slows the production of sleep promoting agents, and that's how it stops you from falling asleep. Spending time like in the bright light during the day, natural light, and keeping the bedroom dark at night by lowering shades or using blackout curtains is something that we highly recommend. So we are able to control the light that we are exposed to, and reducing exposure to light from electronics. Even though you can have like blue light filters, light is light, and trying to avoid any kind of exposures to cell phones or any kind of other television or media would be recommended. Also, regular exercise and consistent routine with meal times is also important to keep in mind and when you are napping. So all of this would be considered as like good sleep hygiene. So watching TV is the top bedtime ritual among US adults, with 52.7% of respondents to a Sleep Foundation poll saying they do it before bed. 50.4% of the people who watch TV before bed get less than 7 hours of sleep, which is less than the recommended amount of sleep time that we have per the ASM criteria. So now getting into eating, alcohol, and caffeine. So eating in the middle of the night, sometimes we tend to get up and think, okay, maybe I'm just going to go get a snack. So eating in the middle of the night is not recommended because it can send like an alerting signal to your body. Like again, light, this can be something that makes your body wake up, and we don't recommend that in the middle of the night. Alcohol can make us fall asleep sooner, but it causes increased wakefulness in the second half of the night. And caffeine is a stimulant, which we sometimes tend to forget. And we always recommend, if you're having sleeping problems, to avoid it after lunchtime. And that way, by the time it's bedtime, it's cleared from your body. Avoiding napping and laying in bed just because is again something we recommend. Napping temporarily improves alertness, and then we lose our sleep drive. As I said earlier, the longer we stay awake, the higher our sleep drive is, and we're able to fall asleep sooner at night when we go to bed. So if you have to nap, which sometimes we all have to, we recommend less than 30 minutes, and this is to avoid cycling through all the sleep stages, and so that way you don't lose your drive. And we avoid napping less than 3 hours before bedtime. So now I'm going to talk about what the psychologists do when they do the CBTI treatment with us. So it's called stimulus control therapy. So in simpler words, habits are usually performed in the presence of specific cues or circumstances, and that is, they are under a stimulus control. So examples of this is, if we always eat when we watch TV, our eating behavior is controlled by the stimulus of watching TV, or lighting a cigarette when one starts driving a car. So we want to break that association, okay? So that is what stimulus control is, and this is what we would work with you to help improve the sleep habits. So break associations between bed and negative sleep outcomes, replacing with positive associations. Go to bed only when sleepy, use the bed only for sleep. If unable to fall asleep within 20 minutes, get out of bed and only return to bed when sleepy. And time spent laying in bed, awake in bed, should be minimized. The other form of therapy that they have is called the restriction therapy, and this is to enhance the sleep drive. So this will help eliminate like prolonged middle of the night awakenings that we can have sometimes. Initially restricts the time spent in bed, and then gradually increases the time spent in bed weekly. So for example, if a person goes to bed at 10 p.m. and gets out of bed at 7 a.m., but says, on an average, they only sleep 6 hours, what we would suggest is, let's try to decrease that time and make it 12 to 6 is what you're going to be sleeping. And then the goal is they're falling asleep and staying asleep that entire time. And then slowly, by 15 minutes or 30 minutes, we increase the uh, amount of time allowed to sleep. And that way we're able to achieve all hours of sleep for the desired number of hours. um, the most important thing I do want to stress on is relaxation therapy, which helps, I think, everyone. The goal here with relaxation therapy is to let sleep happen instead of trying hard to sleep. And with this, like, reducing sleep related worries, relaxation techniques, stress management, these are some things that the psychologist can teach you, or this is something we can find on our own in terms of like yoga or other things that we do. So recommend having like a wind down routine before bedtime. This is a time to engage in activities that are enjoyable yet calming. If the news is going to make you feel stressed or more stimulated or activated, then we recommend not watching the evening news. Those kind of simple things, changes that we can make. And avoid clock watching, like staring at the clock the entire time to see like, oh my God, when am I going to fall asleep, is not going to help either. So I spoke about some types of relaxation techniques here, which most of us, what we tend to use is visualizations, but let me go down the list. So progressive muscle relaxation, so this involves tensing groups of muscles all over the body one by one and then consciously relaxing them again. So this can be learned by listening to a tape, or there are some courses that are available that you can attend and also learn this. Autogenic training again involves focusing awareness on different body parts and consciously relaxing them. And visualizations involve visualizing the like a peaceful, pleasant scenario and imagining yourself breathing quietly, gently falling asleep and having a good night's sleep. There's other types of relaxation techniques also, depending on what the issue that we have is. So now I'm going to talk a little bit about sleep apnea, which is the most common sleep disorder next to insomnia. Um, what are the suggestions that a person might have sleep apnea? So loud or frequent snoring, silent pauses in breathing, what we call apnea, choking or gasping sounds, daytime sleepiness or fatigue, unrefreshing or restless sleep, and morning headaches. And as you can see in sleep apnea, what happens is our muscles are not under our control. So the tongue falls backwards, and depending on how our airway is, there can be obstruction and there's no air flowing through, which can cause decrease in oxygen, brain arousals, and that can have long-term consequences. So diagnosis and treatment of sleep apnea. Sleep study is what we suggest. It can be at-home study or an in-lab in the sleep center study. And what I wanted to stress on the most was there's multiple treat options for sleep apnea. It's not just CPAP therapy. Sometimes maybe using like a lower pressure of CPAP and adding on like an oral appliance or side sleeping devices that we have, or maybe undergoing some nasal polyp surgery would be something, that would work for you. So I would suggest like discussing with the physician if one option fails, and trying out maybe like a multimodal therapy, which we are all training to do nowadays, to see if that is what would help you to decrease your episodes of sleep apnea. Now, restless leg syndrome is also very common. This can contribute to insomnia, and something we should be aware of. And this can be suggested by uncomfortable sensation in the legs, make falling asleep difficult, as I said. Crawling, tingling, itching are usually the words that are used, and it occurs only at rest when you go to bed at night, and it is helped by movement or stretching. The treatment of this is exercise, stretching, before bedtime, replacing iron if your iron levels are low, avoiding caffeine. Caffeine is a trigger of this, avoiding medications, and medications usually like cold medications and such can also trigger restless legs. There's a long list of medications, so kind of paying attention if you have restless legs to what medications might be causing this is good. And then medications itself for restless leg symptoms, and that is decided based on how severe your symptoms are or how frequent your symptoms are. That brings me to the end of my presentation. So I just wanted to summarize. So sleep is essential. Good sleep hygiene goes a long way. And if you have any other sleep disorders, definitely address them with a physician. And consistency in your sleep pattern is the key to having like a good night's sleep.
All right, well, thank you so much for that presentation. If you could stop sharing, and then we will talk a little bit about somebody who has actually had experience with this as a myositis patient. If you have any questions for Dr. Hadagol, you can put it in the Q&A box at the bottom of your screen, and we will have a Q&A session at the end. But right now I'd like to introduce Shauna Nielsen. Many of you may already know her. She was one of our speakers at the virtual summit. Hi, Shauna, how are you doing?
Hi, good. Good to see you both.
Yeah, you want to tell us a little bit more about how you're connected with TMA and your journey?
Sure. So I am a patient that has dermatomyositis. I've had it for about 25 years. I had the skin only part of the disease, the amyopathic myositis first, and then the muscles kicked in about 13 or 14 years ago. I'm super glad we're talking about sleep today. It's been really vital in my recovery journey. Early on, when the muscles hit, I was fatigued all the time, and sleeping during the day was not unusual for me. It was difficult to move and get the exercise. Dermatomyositis, we can't go outside and expose ourselves to that sun like we'd like to. So things got all topsy-turvy for me. Over time, I needed to see a pulmonologist and then a sleep specialist after that. And we determined that for my body, oxygen was very helpful. I would fall asleep driving. Using that shoulder girdle muscles would be really difficult for me. So I started using some oxygen and using it at night. Later, I did the sleep study when I still wasn't waking rested. And when I finally got through the sleep study and got my CPAP, my activity level that had been maybe at about 30 or 40% went up to about 60%. So I got a massive response from the CPAP. So I would encourage people to consider their sleep and whether they're getting enough sleep and waking rested. At the last in-person or virtual conference, one of the doctors did say, myositis patients can have sleep disorders without that kind of choking and snoring. So it is important to get a sleep study if you're finding you're tired a lot of the time. Past that first year or two of treatment, your meds are all in gear, you're doing well, but you still are waking up and having lots of naps during the day. I think it's a really good idea. So I am an RN. I've had myositis for 25 years. I'm a patient advocate. I work with the Northern California TMA Support Keep in Touch group, and we meet virtually online. I've been involved in the video conference and the in-person conferences, and I'm just a huge TMA supporter. We do have lots of videos online on almost any subject, but I'm excited that we'll have sleep add to that group.
We've really been trying to expand our topics as so many things affect a myositis patient that maybe we hadn't covered before. And when I heard that some people were struggling with sleep, as almost every American does, right? But then when you have a chronic illness on top of it, it can really just hurt your recovery, like you said. I had a quick question because I'm kind of new to this. I know what a CPAP is, but I don't know how it differs from a BiPAP.
So sorry, should I go ahead and answer? A CPAP is like when you have like one straight pressure that is given, whereas a BiPAP is a different pressure for inhalation and exhalation. So when do we recommend a BiPAP? Is say somebody, we give them a CPAP and they feel like they're just not able to breathe, or they feel like they're being suffocated, or they have bloating. That's when we would consider using like a BiPAP machine.
Right.
Don't they have newer technology that's less restrictive? I know that some people can feel anxiety wearing this equipment.
Yes, that's right. So two things that we recommend for that is, and especially because I work with the veteran population, I feel like I see that so much more. There are less invasive masks, which just look like nasal cannulas nowadays. So that's something I would recommend, definitely trying different kinds of masks. They're called nasal masks or nasal pillow masks. And then if that doesn't work, you can combine it definitely with what we call desensitization therapy, again, which a psychologist provides. The one I usually recommend is like just wear it and watch TV for the first couple of weeks. Get used to something being on your face and then just move it into the bedroom and see how it works. But definitely trying desensitization therapy is something I would recommend.
Shauna, do you have experience with that? Did you have anxiety with your machine?
I didn't have anxiety because it helped me sleep so much better. I was thrilled with it. I do use a nasal pillow, and the connection for me is at the top of my head, so I can roll all around the bed and it just stays on, almost like oxygen, like Dr. Hedigal was talking about.
You don't ever find yourself ripping it off in your sleep?
I did the first few weeks, and so I liked Dr. Hedigal's recommendation. I wore it watching TV in the afternoon, so the number of hours I needed at night was smaller. The insurance requires you use it a certain number of hours within a certain window of time. I think it's within 60 days. You need to use it 30 days for 5 or 6 hours a night.
Yeah.
And so if I sat up and did some craft or watched TV with it in the afternoon, then I only needed a short time at night to make my little window fit. I also do that kind of sleep hygiene that she was talking about. I would do a warm bath or shower or a warm electric blanket if you're not mobile enough to get in or out of the bath or shower. And then I would do some of my exercises. So if I exercised in the morning, my day was shot. I couldn't do anything else. But I knew I needed to exercise to get stronger. So I would exercise very gently in yoga type breathing exercises with my muscles and then go right to sleep. And it was a restful movement that then allowed me to sleep deeper. So that stretching kind of movements and using muscles. And then I would recover by the morning so that then I felt able to do my life again, that I wasn't working out in the middle of the day and feeling just exhausted. Yeah.
Dr. Hattigel, do you see in your clients variability in what techniques work for each person?
Oh, yes. I feel like it's specialized therapy, right? Like we can't just say like, I'm going to do everything for you and it has to stick. So we kind of have to figure out, I think when we work with the psychologist or when we see them in clinic, it's always trying to figure out what might be the problem. Is it racing thoughts? Is it, like issues in terms of like just waking up multiple times at night, those kind of things. And then based on that, we suggest the particular therapy that we would recommend for them.
Right.
What do they recommend for invasive thoughts? Because I know that happens for a lot of people.
Right. Notes.
So, I mean, it's the simplest thing is like, write it down on a piece of paper and forget about it. It's easier said than done. But what I was talking about in terms of like visualization definitely helps. Kind of like, I mean, yes, we all have problems. There's so many things that we think through. And obviously at night when we are quite calm by ourselves is when those thoughts come racing through our minds. But kind of having ways to cope with it. If it's stress or these thoughts, one is visualization, and progressive muscle relaxation has definitely been something that has been helpful. I didn't say this before, but the VA actually has an app called the CBTI app, Cognitive Behavioral Therapy for Insomnia Coach app, that is available for everybody, not just the veterans, which is a wonderful app which a lot of our patients use in case you don't have the resources to go to see a psychologist.
Right.
What is the name of that app again?
CBTI.
So just go to where you get your apps and type in CBTI and you should be able to find it. Okay.
Yeah, it says like US government app. Yeah.
When I was breathing well at night with my CPAP, I would wake up and remember I forgot to call and make that appointment. I forgot to this or that or the other because I think I was getting better ventilation. And so I did keep a notepad at the side of the bed and write, call the pulmonologist, get the RX renewed, whatever it was that was on my list that I didn't remember during the day, oftentimes would come to me at night. And if I wrote it down, then I could go back to sleep and not worry that I'd forget overnight.
We have a couple of questions. One person was interested in your slides, specifically the slide that has the websites. It went by too fast for them to write it down. Are you able to share that with me and I can email it to attendees?
Sure, I can definitely do that.
Yeah, even if some of our audience cannot write well without it taking a long time or being painful. So it would just help if you emailed it to me and I could send it out.
Sure, yeah.
Okay, so this person, I know you said something about not talking about medication, but we did get a medication question. What medication do you recommend for someone with IBM with REM sleep disorder?
So I didn't get into REM sleep disorder. So REM sleep disorder is when we are acting out our dreams. Usually during REM sleep, we are supposed to be like paralyzed, not be able to act out our dreams. But when we are acting out our dreams, we call it dream enactment, REM behavior disorder. And this medication, there's no proven studies for this, but what has been so far tried and worked is one, melatonin. And for that, you can go up to doses of 12 milligrams. If that doesn't work, then the next step is clonazepam. And if that doesn't work, we also use like pramipexole in some of these patients. I hope that was helpful. But again, it's such a rare disorder. We see it more so in patients who have PTSD and again in the veteran population, but I don't think it's been specifically studied for every myositis kind of picture. So unfortunately, that's all I know.
What about patients with dysphagia?
So patients in terms of, is that in terms of breathing
It must
difficulty?
be in terms of sleep. I'm not sure how dysphagia can affect your sleep. If this person wants to add more to the question, that might be helpful. Because dysphagia is problem swallowing,
Swallowing, yes, that's right.
Would the
which I
fear
guess
be that-
you're only swallowing your saliva at night.
Right, but would the fear be that the pressure would push that saliva into the lungs?
So
That's my
definitely
guess.
patients with dysphagia can be like at a higher risk of aspiration when compared to somebody who does not have it. So that is always a concern. When you have severe aspiration and you have to use your CPAP machine. But again, like depending on which position you sleep in might be something that can be helpful, and on whatever treatment that we're getting for dysphagia is definitely recommended. But if you're high risk for aspiration, we are always cautious about recommending CPAP and BiPAP.
This IBM patient added on, they have a CPAP, but the phlegm still wakes him up.
The phlegm wakes, okay. What kind of a mask do they use? Maybe sometimes, when the pooling of the phlegm happens in like a full face mask, that can wake some people up. So we again recommend like a nasal pillow or nasal mask. Is that something that was already tried?
I don't know, I'm waiting to hear, but okay, that is all our questions. I wanted to talk more to as it is. Oh no, here they come in. Oh, hello, 5 at one time. Oh, it's the one person. Pillow right now. Okay, someone else says, I can't sleep after an infusion. I'm awake for 24 hours.
I would wonder if they're getting steroids with their infusion. And most of our infusions, we start with steroids, but then you can back off of them if you're not having reactions. So immune globulin is one of those infusions. With rituximab, I would try and be the first one in the morning. So again, you might not that first night not sleep, but you should go back to sleeping once that steroid has worn off.
Do you have anything to add, Dr. Hadigal?
No, I mean, wonderful suggestions. I would think the same thing. There's something that is being like a stimulant effect that we see with this. But again, trying to figure out if there is anything that can like calm down or have like a routine that is set in place that might help you get through those days. Easier said than done, I understand, but trying to figure it out will be the hardest step.
Right. Certainly with IVIG, we do use antihistamines, both Benadryl and periactin or cyproheptadine, which can quickly induce sleeping. I know for me personally, it's a very drowsy one of the antihistamines.
We've got a question here. Would eating several pistachio nuts a bit before going to bed provide enough melatonin to positively affect the ability to fall asleep?
Honestly speaking, I do not know the answer to that. I do not know how much melatonin is in pistachio, but something I do want to talk about melatonin as such is when you buy melatonin in pharmacies, look for like there's a label that says if it was an actually well measured melatonin, because it's not FDA regulated as to what the dose of melatonin should be. So they can say 5 milligrams, but they might just have like 0.5 milligrams in them. So look for like the brand mark just to make sure it's good well dosed medications in every single pill.
Huh. This person asked for medications for restless legs.
So the first thing I spoke about is iron supplementation. We just want to make sure you have good iron levels, and that can sometimes some patients might not have increase in their iron levels even after they take the pills. So they may need like IV iron infusion. That is one. And then we get into the list of medications in terms of gabapentin. Medications for like Parkinson's like diseases are used for restless legs. And then there is pramipexole, and there is ropinirole. These are the medications that we usually use for restless legs. If none of these work, then we get into the next set of medications like methadone. And some people also use buprenorphine, but that is like absolute restless legs, cannot sleep, have already gone down all these list of medications. Then the physician might prescribe some controlled substances.
Can gabapentin be safely combined with mental health meds?
Usually we do monitor them, but it is safe. And again, I have a lot of patients on that. It can cause sleepiness, and we kind of watch if it was like an acute case of depression and they are started on a new medication. We just try to watch at that time to see that there's no significant problems. But usually gabapentin, the biggest thing we worry about is like sedation, grogginess, accidents, falls, those kind of
Does it
things.
add to, I don't know if it affects serotonin levels. Can you get too much serotonin if you add gabapentin to your?
Not so much with gabapentin itself.
Good,
Yeah.
good.
With
Okay.
the other medications like pramipexole, ropinirole, there's concern like if we have impulse control disorders, like going online and ordering like a bunch of things or gambling, then they tend to avoid that medication.
Okay. So Shauna, tell us a little bit more about your sleep journey. How long did it take you to get regulated? I know that it can be a vicious cycle when you start napping during the day because you absolutely have to, and then you
Right.
can't sleep at night, which then makes you need to nap the next day. I mean, how do you break through?
It's a challenge. I think I did use the Benadryl and cyproheptadine at times. If I was having a few nights in a row where I couldn't get regulated, I would use it for a night or two and see if I could get back into a regular. I had small children at the time, so sleeping during the day was difficult. Though I did there were, months and months where I slept 16 to 18 hours a day, all night long, and then half the day, in the middle of the day. It took me probably 2 years until the myositis was regulated enough that then I could deal with the sleep more directly. And at that time, I was doing physical therapy and rest, life in the afternoon with kids, and then I was able to be in bed all night. It was really important for me, if I couldn't sleep, to still respect that deep rest, and whether that was meditative, listening to meditation tapes, keeping my eyes closed. Again, I used movement sometimes as, stretching and trying to get myself into that relaxed state. I like Dr. Hadigol's suggestion of those tensing the muscles and then relaxing them and going from your feet all the way up to your neck and your head. That kind of thing with really deep rest was important for me. At times I used acupuncture to induce that deep rest when I was not sleeping well and miserable. Antihistamines, I didn't use melatonin. I didn't use other drugs for it, but getting up and active during the day. Later in my journey, I used a Fitbit to make sure I was getting enough steps every day. And I would just walk around my stairwell or walk around the kitchen island over and over. And I would say, oh, it's getting, close to 6 o'clock. I haven't gotten enough steps. Let me get more steps. That will help me tonight when I go to bed. Again, having that routine. So I would spend some time relaxing, then I would spend some time moving my muscles, get a hot bath, and try and lie in bed or take a herbal tea, drink, whatever that routine was.
You're making me want to go to bed right now, just talking about your routine.
I'd stick
Like,
with
that
it for a
sounds
couple of months,
lovely.
then change it up and say, okay, that may be not working. Let's add something different. And what works better now?
Right. Let's see. I think we have another question. What about white noise rain waves on Alexa?
Oh, my family uses those a lot.
Yeah, I mean, I actually use them with my kids too, I should say, but I think there's like more research needed to like say that yes, this definitely helps. But I know a lot of us tend to use white noise machines. If that helps you drain out the surrounding environment and get into a zone to sleep, definitely I would. I mean, that's not a bad idea.
Yeah.
Shauna, did you have any questions for Dr. Hadigol?
I don't think so. Myositis is so complex. It's hard to hit all of the different angles, but I think we've hit a lot of them today. I just really think that sleep is so important that if you're still struggling, you've got all your medicines for myositis, you're starting to improve, and then you stagnate like I did for a long period of time. it's a really good thing to look at to get and to assure, if you're asking your general practitioner for a sleep study, assure them that you don't need to be snoring and gagging and gasping to be having a myositis related sleep issue, that the Myositis Association does recommend that those of us with daytime sleepiness that's lasting longer than just those first few months when we're on high dose steroids, really, it may pay to have a sleep study. And so
Yeah.
we may
And
need
as
their
I had
encouragement.
Sorry to interrupt, but as I had said, like unrefreshed sleep itself is a sign that, maybe it is sleep apnea.
Right.
Okay, so Dr. Haddigal, what do you hear from your patients the most? I mean, like I personally have oversleeping problems, like Shauna's talking about, where I had depression, I would sleep for a million years. Now I changed to an active lifestyle. So I know for myositis patients, like she said, exercise can make a difference, but I'm trying to find an equilibrium between over exercising and under exercising and hitting that sweet spot, because I'll be tired, but I've got too much energy to nap, but not enough energy to actually feel functional. And I don't know, Shauna, you can tell me if that happens with myositis patients also.
I feel that sometimes too. Yeah.
Yeah.
Yeah, I mean, if the question is like, how do you wire down? Again, it comes down to like having this calming, winding down routine.
Mhm.
And then we don't recommend exercises like 4 hours before bedtime. That can
Okay.
also like help, have this wind down and not be like stimulated too much. Most of the time, what I
Okay.
hear in
Uh-huh.
terms of insomnia is definitely, I'm trying my best, I'm trying my hard to fall asleep, but I'm not able to fall asleep. So that
Mhm.
usually comes down to trying to figure out like, what kind of therapy should we offer as to what exactly might be going on, where they're trying their best, but they're still not able to fall asleep, and offering that.
Well, I've heard a lot about sleep hygiene, but this is the first time that I heard about cognitive behavioral therapy being used to help people sleep for insomnia. And that is incredible. I love hearing about that because I'm sure it helps a lot of people.
Yeah, it is the first line of therapy, actually, that is recommended and actually almost like gold standard in terms of insomnia. As I said, medications can be used, but we don't want to use it as our first go because they only help for a short period of time and they can have long-term side effects.
Yeah. Can we talk
What
a
do you
little?
go ahead?
Can we talk a little bit about when you're on high dose steroids, how early it is, how important it is to take that medication, the steroid dose, really early in the morning if you're on high dose, because that really creates a cycle of unable to sleep when you're so wired on the steroids. Not everyone
Yeah.
feels that, but most people feel really jazzed up.
Yeah. So I mean, when we're on steroids, what we should be thinking about is like eating, one. Definitely making sure we're not because with steroids you also tend to eat more, we have more cravings,
Right.
so that's something we should pay attention to. And the other thing I would be paying attention to is what time, if you have to take a melatonin or whatever that is, like a sleep aid for a short term of time, probably like in 30 minutes 45 minutes before bedtime is what we recommend.
Mhm.
They don't have long duration of action. So even if you took it much earlier in the day, you might not be able to stay asleep through the night, is what I would be concerned about.
Yeah.
Okay, this person is asking how to deal with pressure pain from laying on body with not having much muscle for cushioning without getting a total egg crate bed.
That's a good question. I know a lot of people complain of that. Unfortunately, I think it's just trying to figure out like if you can do like a body pillow or like contoured pillows to see if that helps. But I don't have like a straight one word answer for that, unfortunately.
I do well with a small memory foam mattress, but not the 3-inch, 1-inch, 1.5-inch, because if it gets any bigger, I can't get the muscles to turn over at night. So a little bit of cushion is helpful to me versus the thick one, then it's cumbersome.
Is it like it is in the general population where you have a preference whether you like a softer bed or a firmer bed I mean, my family, they like to sleep on boards practically, and I'm princess in the pea, right? I need it to be really, really soft. But is there more of something that works better for myositis patients because of the muscle issues, or is it still a preference?
I personally I think it's a preference. I haven't read anything about it, but I can look into it a little bit more. I think it's more so a preference in terms of what the bed is. In terms of bedroom and sleep, what has been studied is, like a cool, dark room in terms
Mhm.
of like, I think it's almost up to 67 degrees temperature is what is recommended, because
Okay.
the lower your body temperature is before bedtime, that is easier for you to fall asleep in terms of just the way the hormones are produced. But there's no recommendations as to this type of beds.
My husband likes the 67 and dark. I like a heating blanket almost all the time because it helps get the blood to the muscles that are struggling. And again, for me, at different times of my disease, when I was really immobile, I needed it stiffer so I could roll out of the bed. When I was healthier, I could have more cushion because I had the ability to move and pull up the sheets. So it's a challenge all the way around, and finding what works for you may not work for you over time. It may be one thing in this phase, another thing in this phase. Just be willing to change it up over time to meet your needs, and keep thinking about what it takes to get you to that good sleep.
Do either of you have any final thoughts that you would like to share with the audience?
Is there one more question? Is it normal after 5 hours of working? I'm limping because I feel like my left leg is giving out. Is that normal? Because with walking up and down for 5 hours, someone's in retail and walking a lot.
Oh, is this in regards, probably in regards to restless legs, I'm guessing?
It sounds like it might be, but yes, for
Yeah.
anyone with myositis, if you have damaged muscles and you're using them a whole lot, they're likely to not perform at their best by the end of the day. Definitely, I'm worse at the end of the day than when I wake up in the morning. What do you think, Dr. Hadigal?
Yeah, I would think it's, like fatigue. The
Yeah,
muscles are fatigued. That's probably what is happening, but that would not be a sign of restless legs,
right.
I would say.
Right. Let's see if something else came in. I guess they have a concern about their bed being new. It may help that it gets broken in, I would think, but this person has both dermatomyositis and polymyositis. So is it my bed, and my bed is new? Well, Dr. Hadigal said there's no studies that say whether or not your bed makes a difference. That's kind of a personal journey to go on as to what can work, which can be difficult because beds are expensive.
Expensive. I was going to say that. I mean, it's like, it's not
Gosh.
something you can just try and then like move on. Our
I know,
insurance
and
doesn't cover
they'll
it.
say try it for 30 days and we'll pick it back up, and I don't know if I trust that.
Oh, I have a story.
Go ahead and tell us, because we got
We got a
7 minutes.
mattress when we were newly married, and they refused to take it back, Where do you get rid of a mattress? That's horrible. I drove up to the place and dumped it off the top of my car and drove off. It was so bad. We bought a different one. My daughter can't understand why we don't want to buy a new mattress ever. It's like, oh, you don't even know the story. But it is hard. And adding a small foam, something for $100. Again, I wouldn't go with the thickest one you can get, but a smaller one might give you that cushioning, because especially with myositis and steroids, we do tend to, the fat pads move. And so you may not have fat in the places. I need a double mouse pad just for my elbow, or it bothers my nerves. So needing cushioning on your bed is definitely something that we will talk about, and we do need sometimes. So I'd go with the smaller alterations as opposed to the whole new mattress.
So Dr. Hadigal, how do you encourage your patients to keep working towards getting a good night's sleep?
I would say consistency is the key. Having a routine that you have figured out works for you. If you have to have a sleep diary to figure out what works for you, because sometimes we don't always remember what we did like last month that was better for us, and now we are stressed out and we're not able to sleep. So being consistent, figuring out what works for you is the first step.
All right. Well, thanks to both of you so much for joining us tonight. We really appreciate your expertise, Dr. Hadigal, and your wealth of knowledge and quarter of a century of having myositis, which I'm sure is
Way too long.
You're like, do I win a prize for this? What? Do I get a gold star? But no, we appreciate you both so much, and we look forward to having you again on our shows. And I will let the audience know that our next Ask the Doc is going to be June 15th with Dr. Lisa Christopher Stein, rheumatologist, and you can bring your questions to her, and we look forward to having you there. For TMA, I'm Rachel Bromley. Good night.
Bye. Thank you.